All right, so let's start. Let's start the thorax then. So, first of all, we just want to identify the different components of the thorax, its basic functions. So, what are some of the functions of the thorax? Protection, yes. Protects the heart, protects what else? Lungs, what else?
Vessels and many organs in the thorax.
Yep, vessels, trachea, esophagus, all that good stuff. Good. What else is the thorax important for?
Heart.
Breathing.
Heart? Yes. Breathing, yes. Respiration.
Well, you said lungs.
Good. What other types of functions can you think of?
Cardiac output.
Cardiac output? Well, that's getting real specific there.
Well, I mean, moving blood from the body.
Absolutely. So that's part of it. But think of the thorax as a whole structure.
Passing heart with any solid or something.
Yeah.
It's a corridor, right?
Corridor.
Or conduit. Or things going from the neck and head down to the lower parts of the body.
Structure.
Structural support for the upper limbs, right? Good. So then we've got the different components of it. Obviously, we've got the vertebral column back here, the sternum, the ribs, that's the bony support structures of it. We have the pleural cavity, so there's components here, right? Pleural cavity, left pleural cavity, containing the lungs, obviously. And then we have the mediastinum, which is that central area, contains the heart, esophagus, trachea, major vessels, etc. Okay, so the top of the thorax has the superior aperture. Okay, and that is formed by the circle of the first rib, the vertebral column, and the top of the manubrium. And it provides passageway for anything coming anteriorly out of the thorax. It's a passageway for anything coming out of the thorax superiorly. Okay.
You said first rib and what, sorry?
The first rib and the top of the manubrium, as well as the vertebral column there. All right, bottom aperture, so inferior aperture. It runs along the bottom of the floating ribs and the costal cartilage of the false ribs, as well as this last true rib. And right along vertebra T12, it's obviously that's the junction between thorax and lumbar vertebrae. And that is also where the diaphragm attaches. You can see it attaching to the lower margins of the ribs and the costal cartilage, and then as a dome up into the thorax. So there's some overlap between the exterior part of the thoracic cavity and the abdominal cavity because of this dome action of the diaphragm. A couple of things to point out in the diaphragm. We've got the aortic hiatus here and the esophageal hiatus, so providing passageways for the aorta and the esophagus to move through down into the abdomen. And remember, the diaphragm is about 4 muscles all tethered together with the central tendon tethering them together there. So we'll talk more about the diaphragm in a later lecture. So that is the inferior aperture. Excuse me, guys. Right. We also have the mediastinum. So That's this section between the lungs, basically, contains the heart and trachea, esophagus, and it's divided into the superior mediastinum, so above the sternal angle, and the T4, T5 vertebral level. Yes.
I had a question yesterday.
Yeah.
Sternal angle and the manubrial-sternal joint is the same?
So the manubrial sternal joint is the junction between the two bones. The angle between them is the sternal angle.
But it's in the...
It's
the same
exactly the
spot.
same spot. So the
location.
apex of that sternal angle is at the manubrial sternal joint.
Okay, okay.
Yeah. Good question.
Yeah, I was just wondering because I'm not sure how would you, if you pointed it out in the lab, like with a pin or something, how would you?
Right, so I would accept either one as
Okay,
correct.
that's...
Excuse me. So the superior mediastinum goes from the superior aperture down to the T4, T5 level, that transverse plane there. And the inferior mediastinum is from there down to the bottom of the diaphragm.
Considered from where? Oh, it's from the diet.
Yeah, down from this junction point between the two, so the sternal angle level, T4, T5 level, down to the bottom of the diaphragm, which is curved, so. Then we have the anterior mediastinum, which is in front of the heart. The middle mediastinum, which is right around the heart, and the posterior mediastinum, which is behind and slightly inferior to the heart in parts. So, knowing these different designations for the different parts of the mediastinum may help in knowing where different structures are in relation to each other. So, kind of give you some spatial orientation. Hopefully that will be helpful. Come on, there we go. Okay. So you can see here just a couple more. What I'm looking for. Oh my gosh, I'm tired. Just another angle so we can see a little bit more. We've got the pleural cavity here, which surrounds each lung, extends down into the costal diaphragmatic recess here. So even a little bit further down than the lung goes. Excuse me. And then also note that the apex of the right lung extends up above the thorax proper. So it actually is intruding into the base of the neck. So when you've got a injury to the base of the neck, you not only need to be thinking about all the structures that we think of typically in the neck, you also need to be thinking of what's possible, what possible injuries there might be to the apex of the lungs. Okay, and we'll talk more about the pleura, but remember we've got the double layer pleura, the parietal pleura layer, and the visceral pleural layer. Yes.
So in the costal diaphragmatic recess, is that when you have blood in your pleural space, is that where it would accumulate?
First, yeah.
Okay.
Yep, good. And then you can see here the mediastinum kind of set in between the pleural cavities. So just another way of looking at this division of the thorax.
I'm sorry, where does blood accumulate?
So when you've got pleural edema or blood in the pleural sac, it's likely to begin cooling in the costodiaphragmatic recess. It's the lower portion. Okay. So then when we talk about the relationship of the thorax to the organ superior to it, or the regions of the body superior to it, we think about like the head and neck. It's all the structures that are passing in through the thorax up to the head and neck. So we have obviously the vertebral column continuing on up, and the spinal cord continuing on up, the trachea and the esophagus, all of the cerebral and cervical blood flow, so all the blood flow up to the head and neck, and the innervation spinal nerves that goes into the head and neck. So that's all continuing on from the thorax. And a lot of these here are going to be some of the sympathetic fibers that are coming up from the thoracic part of the word I'm looking for, sympathetic trunk. Goodness. All right, so that's the easy one. We also have, again, like I said, support of the upper limbs. So we have our pectoral girdle, which is comprised of the scapula, the clavicle, and the acromion here. So this all comprises the pectoral girdle, which is adhered to the thoracic wall with the muscles and ligaments there, as well as we have the subclavian artery and vein coming out from the thorax and down into the upper limb. So the connections there between all of them, just make sure you're fusing all of these regions you're studying together into a whole. When you're studying just one region, it's easy to let it just become isolated, but let's always remind ourselves what are the connections between the relationships between them. So on the inferior aspect, we have relationship with the abdomen, right? And that is the border between the thorax and the abdomen is the diaphragm. And so on the previous slide, I showed you the esophageal hiatus, and this one gives us a little more detail. So at level T10, the aortic hiatus at T12, and we also have the caval opening for the inferior vena cava at about T8. If I can read this. So again, we've got continuation of structures that are throughout the trunk through the diaphragm and connecting these two regions. Just make sure we remember the connections between the two. All right, so then a couple of features. So I already touched on this. So a horizontal plane between T4 and T5 also runs straight through the sternal angle, and this gives us a reference point for several different internal organs. And Cassandra was talking about them in lab, so can we shout them out?
Where trachea splits.
Mm-hmm. Where we have tracheal bifurcation here.
Top of the pericardial sac,
Yep, top of the pericardial sac. So
arch, both sides of the arch of the aorta.
yep, so that is the margins of the aortic arch. It's also the superior mediastinum is above it versus the inferior as we find it. Also is the costochondral joint or the sternocostal joint of rib 2. So this joint is also at that level. Okay, so that just gives us some reference of what else is going on. In addition, this is the level where the superior vena cava enters the pericardial sac and actually enters the heart. Okay, so those are some useful positional things with some surface anatomy that we'll be able to correlate and identify versus with what's actually inside the thoracic cavity. All right. Any questions on general organization? All right, super easy. This should be a lot of review stuff for you since we've been covering it in the lab for the last couple of weeks. So, this is the venous drainage of the thoracic cavity, and so we have these veins here, which are the, don't look at the
Intercostal.
yeah, intercostal veins, and they drain into the hemiazygos and accessory hemiazygos and zygos veins, and then those then drain into the superior vena cava and inferior vena cava, superior vena cava or the azygos vein, to then empty in the heart. So we have one sequence of vessels I want you to be familiar with is going from the accessory hemizygos, so we'll label that number 1, emptying into the azygos here, as well as the hemiazygos also emptying into the azygos, and then emptying into the superior vena cava. So that's a good sequence of vessels to know. We also have our brachiocephalic veins, like we've been studying. You can see them here at the junction between the left internal jugular vein and the internal jugular veins and the subclavian veins. So it's supposed to be Okay, so just be familiar with all of these veins. These are some of the major veins of the thorax and some of the major systemic veins of the whole body. So be familiar with them. All right, so then we talked about the arteries. So we have the aorta that fit into wow, I really need to get more sleep. Ascending aorta into the arch of the aorta. And then just as quick review, branches off of the arch of the aorta are first the brachiocephalic trunk, which is next.
Common carotid.
Left common carotid. And then the
Subclavian.
there you go, that's subclavian, good. Off of the subclavian arteries, we have a branch that runs down either side of the sternum. Those are the internal thoracic arteries, good. And then from those, the internal thoracic arteries, we have the branches off of them for the anterior intercostal arteries. And off of the, now you can label it, you know. Here we go, thoracic aorta. We have the branches of the posterior intercostal arteries. Ooh, trouble with words today. Okay, so know the pathway for blood supply. Again, these are the major vessels of the thorax. We need to be familiar with them. And what splits into what and leads into what and all of that. All right, so then we also have our intercostal nerves rising from the spinal nerves in the thoracic cavity and also the sympathetic ganglia, and coming out around the intercostal groove at each level. And they segmentally, as we've been studying with the nervous system in general, segmentally correlate to the dermatomyotomes. The only one that is not directly associated with the segment in the thorax is T1. That innervates the upper arm, or the upper limb, so the lower part of the upper limb. But the rest of them are segmentally down the thorax, just like we have for the ribs.
So then for someone that has a lesion between C7 and T1,
Mm-hmm.
well, I mean, between T2 and T3, that they can still raise their arm, they just can't do anything with their fingers.
So a lesion between T2 and T3, you said? Or T1 and T2?
T1.
Okay, so if you have a lesion here, T1 and T2, you would lose some of your abilities of the forearm, so you probably lose a little bit of finger dexterity.
Yeah. Oh, I actually meant before that. So it'd be between C. So you still have pretty much, if you still have T1 and T2, you can move your arm, but
Absolutely.
but you can't.
Yeah, so here you would have pretty close to full arm function. You probably have a little bit of problem with some of the back muscles controlling the arm.
Okay.
But you'd have full finger dexterity because these two are not affected.
Okay.
And then we'd have just problems below with the trunk and,
Okay.
and
Yeah.
lower limbs.
Makes
Okay?
sense.
Yeah. Good. Whoa, back up. Too much. Okay. And then just a reminder that our sympathetic chain ganglia emerge between T1 and L2. So again, that's important structures within the thorax, extending slightly beyond it, but within the thorax and running along either side, like we saw with the paravertebral ganglion on cadaver 4. All right, so then another key aspect of the thorax is its ability to expand. So we have muscles that elevate the ribs during inspiration. So the ribs kind of act like a hinge joint. So here's the vertebral column. This guy's got some serious kyphosis going on. Here's some ribs coming out. So when we
Beautiful.
isn't that lovely?
Yeah.
So when the individual inhales, the ribs will actually swing up, kind of like a handle of a bucket. And that's
exactly what I
because of
think
the
of.
angles of them actually expand the cavity that you can see here. They've got the little green sternum here. You can see it's actually out elevated, and the ribs have moved up and out. So during inspiration to help expand the thoracic cavity. Okay, another structure that's really important to remember, we just studied, is the phrenic nerves. So left and right phrenic nerves coming up from C3, C4, and C5, spinal nerves. They're bundled together. And going down to innervate the diaphragm. There also is the pericardial branch of the phrenic nerve that innervates the pericardium of the heart. So we're all familiar with that from lab. Just make sure we know it on the diagrams too. And you can see why we see the phrenic nerve in the location we do, kind of hanging out in the middle of the thorax in the cadavers after it's been dissected. You can see it just runs right there along the edges of the heart.
So C3 through C5, do you innervate that?
They are,
That's where the
Oh,
phrenic
blank.
nerve-
yes, they are the ones that comprise the phrenic nerve. Yeah, so typically you have a spinal nerve and then they bundle into a bigger nerve together and they travel out from there. Especially with some of the cervical ones. All right, so then let's move on to some regional anatomy in the last few minutes. So we'll start with pectoral anatomy, and the different components of pectoral region is obviously
Me too.
the pectoral muscles, some of the pectoral vessels, blood vessels, I was really going for, lymphatic vessels, and then the breast too. So we have the breast is adhered anteriorly to the pectoral wall. It's just superficial to the deep fascia, right over the pectoralis major muscle,
Never gonna think of.
and includes the secretory glands here, lactiferous ducts, so the ducts leading from the secretory glands, or the secretory lobules is what they're called, to the lactiferous sinuses, and then out the nipple. And just a little better example of it from, for at least the blood vessels and everything. So then we see the secretory lobules tucked in behind here. And secretory lobules are actually modified sweat glands. Instead of producing sweat, they produce milk, which is a combination of the proteins and fats, a little bit of secreted antibodies as well, IgA antibodies. I'll go into that wonderful baby sustaining fluid. All right, so then we have innervation of the breast from, where is it? The lateral thoracic artery, and the pectoral branch of the thoracoacromial artery. Trouble with this. and branches of the internal thoracic artery. So there, and there's also branches down here, you can see here. The lateral thoracic artery is a branch of the axillary artery, which, the axillary artery, does anybody know what it was named before it became the axillary artery?
Subclavian.
The subclavian, yep. Okay. The vessels or the veins that drain the area run parallel to the artery, so they're just right in there together, and they drain into the axillary vein and the internal thoracic vein and intercostal veins, which they don't really show on here. So major veins. Oop. Intercostal, axillary, and blanking on the other one at the moment, internal thoracic. Okay. We also have lymph drainage, so the lymph vessels that drain the breast are usually go to the pectoral axillary nodes or the lateral axillary nodes. Some of them go to the peristernal nodes as well. And then they pass into the bronchio having trouble with my words. Help me out with the word here.
Mediastinal.
Thank you. Bronchomediastinal ducts, trunks of the lymphatic system. So just a reminder here of the overall major trunks of the lymphatic system, and also some of them drain into the subclavian trunk as well. Yeah, so approximately 70% of the 75% of the lymph actually drains into the axillary nodes. So just a little bit into the peristernal nodes. Some also drain into the thoracic duct. So several different routes for the lymph to drain back into the larger lymph vessels. Is that all I was going to say on this one? No. So then also there's, actually it'd be better on this diagram back here. So in between the lobules and the fat that's embedded in the breast, then we also have suspensory ligaments, so little bunches of connective tissue that then coalesce into the suspensory ligaments of the breast that are right along the under the dermis of the skin, so that the deep layer of the skin, and help support the breast. And one thing clinically is that when you have a breast cancer, so the tumors in the breast will actually create pitting in the surface of the breast, because they are actually creating more tension on these suspensory ligaments and pulling them down, causing that characteristic pitting of breast cancer.
Can you repeat that again about the suspensory ligaments?
Yeah, so
The
it's a
skin.
bunch of connective tissue that then coalesces into these suspensory ligaments and are associated with the dermis of the skin, so right underneath the skin. And then often when you have a tumor in the breast, it will create extra tension and cause a characteristic pitting of the surface of the breast. So doing a breast exam, that's one of the things you're looking for.
So, and what do the suspensory ligaments attach to? Are they just
Yeah, so
to the dermis, you said?
They are associated with the dermis and will attach
Oh, okay.
to the layers of the fascia underneath, so the
Okay.
superficial fascia right underneath.
And what do they do?
Just support the breast.
Okay.
Any other questions? Okay. And then we have our secretory lobules that there you can see them that are producing the milk and secreting the antibodies. All right. external surface, we have the areola here, the pigmented area around the nipple, and the nipple has about 15 to 20 openings for the lactiferous ducts coming. So it's not just a single duct, lots of small ducts opening into the surface of the nipple. That was everything I was going to cover with that. Yep. I think so. Okay, so that's what I had time to cover today. We'll continue on with musculature and other things next week. Questions?
I just have a question. Is there a way you can make your lecture notes go in order with your PowerPoints?
Typically I do that, but last night didn't work so well.
Not even last night, I feel like they've just been like that. It like jumps